Let me start, as you're all adjusting, to say thank you to a couple of colleagues. First, as was noted, I spent nearly 8 years as the state health officer in Arkansas. I was very honored to be able to represent the people in Arkansas and their health issues. I wanted to acknowledge, and I don't really have an opportunity frequently to do this, my federal colleagues in whom state health officers depend so much every day for the work that we do. We don't do it in isolation, and our work is made better because of that collegial relationship that we have with our federal colleagues that make up the federal and state local public health systems. So thanks to my colleagues from CDC, especially Rob and Steve that were here and spoke before. And since I'm not going to get a chance to stay to hear Dr. Goldman speak, let me say thanks to David for his good work and the work of his team. We also depend so much on all of the work across the various federal agencies in doing our work at the state. I'm also going to deliberately begin to sort of move in a different direction. I'm going to ask you to think a little bit differently. We're going to move to the different side of the brain. You've been at a fairly minute level as it relates to looking at the science around antimicrobial resistance and statistics. And according to what Dick had asked me to do, he wanted me to help you think about the policy implications related to public health and how we make change at a population level, and perhaps to give some thoughts and some examples related to the policy development process. So I'm going to go there, so that I'm not going to be able to, in this presentation, spend a lot of time quoting specific studies and statistics, but rather to think about how we might build a bridge between public health, between human medicine, between animal medicine, and frankly, in terms of thinking through how we change the culture of health in our country. To do that, I want to start by just a quick detour as it relates to building the foundation in understanding public health and what we do, why we do what we do, and sort of the various functions. For many people that may encounter only parts of public health, there's a mystery around what public health really is and why it's important. And so I want to take a moment to just sort of stress a few of the issues that we deal with in public health, one of which is assessment. Now, there are three core functions in public health, one of which is assessment, and that's very broadly defined to include our epidemiologic assessment and surveillance, but also to include assessment of various health conditions and the development of a diagnosis, essentially looking from a population perspective. Second is the whole notion around policy development, and again, that's the subject of my talk today, is to help you begin to think through the elements around policy development. I would suggest to you it is one of the most important aspects of the work that we do in public health. It certainly has one of the greatest impacts on the health of the population done correctly. And I also believe it is probably one of the most important initiatives or interventions that we in public health undertake. That being said, I'm not going to suggest to you that we always do it very well. Policy development is one of those things that is quite imprecise, and it depends on so many different factors, some of which I'll try to talk about today. And the third, which is related to the assurance, that is to say that public health does not have the responsibility to always intervene, to implement everything that needs to be done, but it certainly is public health's responsibility to assure that certain things are corrected, are fixed, or undertaken in an effort to implement appropriate strategies and interventions. So those three core functions are important. And I would say to you that, and again in full disclosure, we came up with these three core functions of public health as a result of a very deliberative examination of public health that in 1988 found that public health generally in the United States was in disarray. And that's a fairly broad indictment on public health in our nation, and I think it was a recognition in many ways that we've had neglected the basic public health infrastructure in our country, and that if we really were serious about increasing the health of the public and protecting the health of our citizens, we needed to do a better job. Policy development, frankly, was one of those areas where it was quite damning, because there was a general belief by our scientists in public health that the facts should speak for themselves. That if you just studied it and you came up with the right answer, that it would logically follow that we should then do what is the right thing. And the reality is that the science generally doesn't speak for itself, and that it's not good enough to simply have the right answer, but in fact that we must move towards being able to develop effective policy that can in fact be supported by the public and by policymakers, and that is not entirely a scientific conversation. In 1999, the CDC named the 10 greatest public health achievements in the 20th century, and I'll show that to you in a moment. But one of the most important things I think to acknowledge is that that there had been an increase in life expectancy since 1900 of some 30 years. Of that 30-year gain in life expectancy, which frankly is quite remarkable, 25 of those years could be credited to advancements made in public health, and less than 4 years towards the improvement in medical care and access to medical care. Why is that important? Well, it goes to the issue that this is really about the work that's done within public health, within the context of the acknowledgement of the work that's done looking at the population level interventions, many of which are related to changes in the environment. It's issues around making sure that where you put where you dig the pit for the privy is not over the water supply. It's things like that create for us the understanding and the ability to make the most significant impact. So again, looking at changes in life expectancy, the top 10 achievements include vaccination, motor vehicle safety, safer workplaces, control of infectious diseases, decline in deaths from coronary heart disease, safer and healthier foods, healthier mothers and babies, family planning, fluoridation of drinking water, and recognition of tobacco use as a health hazard. So of those 10 things that you see, do you see anything controversial there? I think you do. And that's part of the world that we live in public health, particularly as it relates to policy development. I'm going to review a few of those areas that we encountered in Arkansas when I was there, but also, frankly, we've been working through in all of our states to various degrees as it relates to broad policy issues that have an impact on health. Again, part of the issue here, and I'm not going to go in detail through this, but it's beginning to look at the determinants of population health. And again, let me just suggest to you that individual behavior sort of is at the center, and that's where we have the greatest influence potentially as it relates to intervening with individual people. But as we begin to think through how do you change the health of populations or groups of people or society, we really see that those broader changes in the context of how we live, the living and working conditions, social and community networks and so forth, if we really want to make the greatest difference, we really need to move beyond the individual to look at the group, environment, and culture, and that really, again, is at the crux of where our policy is. Sometimes there's a discussion around what we refer to as a social-ecological model, and again, I'm bringing this up to frame the construct of policy development, again, thinking through how the relationship of policy on society and community relate in terms of how we collectively make decisions. This next slide, I think, is important because there is an important recognition in policy development that there are many different aspects of policy not just one size fits all. And you heard Dr. Dwelly talk about his policy at the hospital that described as a condition of having clinical privileges, there was a set of rules that the medical staff had agreed to live by, and they essentially created a private policy. And that policy, whether it's the policy of a company, of a university, of a government agency, all of those private policies are generally much quicker to get accomplished and frankly can be customized to the greatest extent possible to meet the needs of the individual organizations or societies. And again, it is an important aspect of policy development. It's frequently not seen as important as it really is from a public health perspective. But again, you really should not underestimate the importance of private policy making, particularly when you think about large employers. And if you look across the spectrum in your states, you'll find that you have a number of large employers, any one of which could make a policy change that would have a substantial impact on the individuals and the families. And if you want to look at some examples, take a look, for example, at health insurance policies that provide support for or credit to individuals who sign a non-tobacco attestation, essentially creating a credit or a financial incentive for not smoking, and therefore creating a policy initiative to favor non-smoking or non-use of tobacco. In and of itself, an important policy, and again, it doesn't require a change in the law. It requires a change in desire or the governance of the individual organization, which is important. Another policy I would suggest to you that is in force that we're seeing across the country, and certainly that we saw when I was in Arkansas, was, for example, a requirement that individuals that are working in either health care or public health annually get a flu shot. We simply said the facts are clear, and people who come to the hospital or to public health for services ought not to be at risk from getting the flu from somebody that actually should be taking care of them. And so there was enough clarity that the health care providers and the public health agency simply made a policy that says, as a condition of employment, we expect that individuals will get a flu shot if you want to be part of the team. And the reality was that private policy had substantial impacts and a positive health effect. Rules and regulations, again, at an agency level, and I would suggest, again, from the public health perspective, there are rules and regulations have the same effect as law, but they follow a very prescribed process that I'll talk a little bit about that provides for substantial public input. It does also take, as Dick mentioned, time. But in some cases, it needn't take an enormous amount of time, and I think properly done is a very effective mechanism for public health policy development. And then again, statutes and ordinances. Again, the idea at a local level, the ordinance could be relatively quick. At the state level, the statute could also be quick. But the point of it is that there's public deliberation, and we consider testimony on all sides on many of these issues. So one of the things that sometimes is a mystery around rules and regulations at a state level, again, as Dick mentioned, the federal rules take on a life of their own and sometimes can take multiple years to get changed. But at a state level, it's reasonably clear algorithm for how regulations are made, and it's more of a 6 to 9 month process, at least it was in my state, when it came to enacting regulations or regulatory changes. First of all, there needs to be enabling legislation that provides the context of the regulation. You simply can't go off and pass a regulation or create a regulation unless there's underlying enabling legislation that provides for it. Usually that means that the legislature will pass a law and say, we're going to create, for example, a trauma system in our state, and we ask the state Board of Health to enact regulations to actually implement the sense of the regulation. So that's, or the sense of the statute. So that's how statutes become the basis for the regulatory change. Internal or external cases made for regulatory change or initiation. In some cases, the law says the agency must or will or shall, and in other cases, the regulation, the statute provides discretion and essentially allows the agency, on the basis of what it perceives as a need for a change in law or policy. Then the agency might create the first draft. The vetting process may include informal or formal consultation as may be needed. Initial approval by the board, usually the Board of Health in our case, and in many cases in many states, has to first of all approve the issuance of draft regulations. There is a prescribed public hearing process, a review of the public hearing comments, and then a redraft or issuance for board approval if there are substantial changes made as a result of public hearing. Legislative review, again, this depends on the jurisdiction and the rules related to the regulation and regulatory promulgation. In some states, the governor might be required to sign agency regulations, and in almost every case, there's a need to file the regulations with the Secretary of State, and then there's an enactment period after a certain waiting period. The bottom line is that the policy, the regulation actually has the effect of law and goes through a vetting process that creates substantial opportunities for public input and comment. There is, and again, I know this is a kind of a busy slide, but part of the issue here is that there is really a framework for evidence-based public health and the evaluation of scientific evidence to support changes in regulation and law. This happens to be a model that was developed by a colleague, Ross Brownson, who's done an outstanding job in developing an entire body of work that really relates to the importance of evidence-based evaluation of data in support of regulation, and this sort of stepwise process is very well known to public health folks who are involved in this kind of work, but it helps to create sort of a taxonomy related to our policy development efforts. And it calls for rigorous evaluation of the data, of scientific literature, of receiving testimony, and beginning to make sure that as the process of policy development is accomplished, it's done so in a very rigorous and thoughtful way. I also want to acknowledge the fact that there is no policy development that's devoid of politics. And that's the reality of the world that we live in. I often said to my governor, because I had the pleasure of working for two governors, one Republican and one Democrat. A number of the legislators that I worked with frequently would say, "Well, gee, it's how do you get along with those Democrats or Republicans?" And I'd say, "Well, in my view, public health is by its nature political because of the world that we're in, but it needn't be partisan." And that's my strong belief that public health is not a partisan sport, but in fact it really relates to the facts that we, from a science perspective, can employ in the use of public health decision making. But that being said, the ability to promulgate effective policies in public health is influenced by the political environment, and it's important to recognize that public health people need to acknowledge the importance of actually understanding the context in which the work is done. If there is no perceived problem, then the solution may simply be a solution looking for a problem, or so it will seem to legislators. And so making the case for why regulation or policy change needs to occur is really important. And then, of course, our potential solutions. But you need to acknowledge also the political dynamics of the time. There are many circumstances in which, even though the best answer is raise taxes, The political dynamics are such that that's probably not going to be an acceptable solution in many circumstances. But I will tell you, one of the most effective ways in which to reduce tobacco use is to raise taxes and therefore the price of tobacco. But you needn't go very far, except for where we're at, I think, here in Kansas City. I think the folks in Missouri have had a very difficult time getting an increase in their tobacco tax, despite the clear scientific evidence to support increasing cost of tobacco reduces utilization, and particularly for the youth, and that is an important policy dynamic. So the fact of the matter is that all of these things come together into making the decision and creating that window of opportunity for policy change. Again, one of the best examples that we see in policy change in the public health sphere has to do with prices. And again, whether you call it a tax or I've seen a couple of states now that know that they don't want to use the word tax. So I've actually seen a couple of states that have used the term user fee because that really is pretty close to being correct. The average cost, by the way, we looked at it in Indiana. The average pack of cigarettes, $5 and some cents. The average cost per pack is about $15. If you look at the total costs related to medical costs, lost productivity, and overall cost to society. So it's one of those things where we know that there is a burden that society and government will pay as a result of the use of tobacco. And so the term user fee is actually not that far out of bounds in terms of accuracy. Nevertheless, taxes sometimes, increasingly right now, are very difficult to manage, but we know that it's an effective policy strategy. Environmental control means putting restrictions on where and when you can smoke and who can smoke. All of those we know will make a substantial change. And then education related to tobacco use, including, by the way, the warnings on the sides, the pictures in some cases on the sides of tobacco packaging, will make a difference. These three factors make a substantial dent in tobacco use, all of which relate to an evidence-based approach to tobacco. Now, in my state of Arkansas, when I was there, I'm proud to say we were able to increase the price of tobacco, both cigarettes as well as cigars and pipe tobacco. It did result in a reduction in use, and by the way, there was a real dividend paid because we were able to use that increased tax revenue to offset the cost of chronic disease in our state, as well as to fund a trauma system that was desperately needed for the state, because again, injury is the leading cause of death for all people between the ages of 1 and 44. So it's quite a nice idea to tax tobacco, use the proceeds to pay for another public health cause, which in this case was injury. But that relates to the fact that that we have to be able to demonstrate substantial harm and the use of taxes and, in this case, prices to have an impact. Well, and here's sort of the proof of the pudding. If you look at cigarette smoking from 1965 through 2005, you see substantial decreases, but you also see the red line there, which is high school students smoking. And again, there has been, we really have an area that we need to pay a lot of attention to in terms of our youth smoking behavior, and increasingly in many of our states, the substantial still rate of smoking by pregnant women, in particular pregnant teenagers, is a substantial public health burden, and one of which again needs to be addressed in a more direct way. So here's another issue, seatbelt use. The point of it is that there are a number of interventions that we know work. Seatbelts work. You would be surprised to perhaps know that not all states have a primary seatbelt law. We know that primary seatbelt laws impact both morbidity and mortality from car crashes. So the question is then, why is it that we don't have primary seatbelt laws in every state? The answer, again, it has to do with a trade-off between personal freedom and government action. And it's not solely a matter of looking at the science. It's also a matter of looking at the trade-off and the environment in which the regulation occurs. But you can see the estimated lives saved by seatbelt use is shown in this graph. It's clear what the answer is. It's not always clear how to make the policy changes as we would all like to see. Here's another one related to dental caries. The community water fluoridation has clearly been ranked one of the 10 great public health achievements of the 20th century. Fluoride occurs naturally in all drinking water in varying concentrations. As far back as 1931, Dr. McKay proved that naturally occurring fluoride in the water supply could inhibit dental caries. We now know it is entirely possible for a child who has both fluoride in their water and dental sealants on their teeth to actually grow up with no cavities at all. And I don't know about you, but I grew up with a mouthful of cavities. But you know, it's now possible for our kids to actually never understand what it's like to have a cavity in their mouth with proper oral health. The reality is that not everybody buys the idea of fluoridation as being good. Despite the fact that there have been numerous studies that go back for many, many years, there continues to be people who fervently believe that fluoridation, added fluoride in the water system, is a government plot, that it creates all kinds of problems. And again, I'm not trying to poke fun at this, because I do believe, in talking with a number of people, that they genuinely believe it, and they also believe they have the facts to support their assertion. So these are facts in dispute. Despite that, in Arkansas, we were able to prevail in terms of getting fluoride in the water supply by passing a law that requires a certain level of fluoride in our drinking water serving populations of 5,000 or greater. We were substantially lower than the U.S. average in terms of fluoridation in our water supply. We were able to through both the use of education and around the benefits of fluoridation and working with our legislative policymakers to get that policy change within the last couple of years. But it was very difficult. And again, the discussion on both sides of this issue was substantial and heated. And so there are, despite the fact that we have many years of well-founded scientific studies, there are people, and not just the concerned layperson, but frankly, some of our most ardent critics were other physicians and in some cases public health professionals who came to testify against fluoridation. So it's not simply good enough to say the science should lead us to that conclusion. It also recognizes the importance of making a cultural adaptation to and understanding of the culture to make sure that it fits. Let me give you an example of another success story, and that relates to our ability to move quickly. And this is a circumstance where, although regulation can take a long time, I think we were in Arkansas able to go from the beginning of the initiation of an understanding of a problem to a regulatory emergency regulation within about 2 months, when we discovered the ample and freely available access to K2 or spice. In some cases they're called bath salts, another substance. But the point of it is there were substances available for sale in convenience stores that wound up in being used in ways that were not helpful, in fact harmful to public health, to human health. And we were able to move quickly, again, from the perspective of working with clinicians and law enforcement to begin to put laws a regulation in effect to curb the availability of these, in this case, synthetic drugs. We were able to change that very quickly. And again, this is an example where public education was very important. We worked with the media to get the word out, and we worked across a whole number of disciplines to be able to make things work. Well, here's another example that didn't work out quite so well, and this has to do with raw milk. For many years, Arkansas, like many states, had a law that prohibited the sale and distribution of raw milk, and many of our public health physicians could remind you of the days gone by when people died because of contaminants in raw milk, and the reason for pasteurization and the reasons for changing the laws related to processing of milk were in direct relationship to the risk to human health. And yet, in this 2 years ago, actually, we saw the sale of raw milk become available in Arkansas, as it now is in several states. This is despite the fact that there are several good studies and a lot of good work done by public health scientists and across multiple sectors for many years around the nature of the dangers related to raw milk, but nevertheless strong feelings about the health benefits of raw milk and the ability for individuals to, if they want, make a choice to buy whatever they want. And so, again, this is just to point out that, again, the science does not necessarily speak for itself, and in some cases, the society's desires and what they believe based upon science that we may not believe to be entirely correct or accurate may sometimes be used to support changes which frankly, in our belief, go against good public health. So those were just some examples of policy development that we've gone through, we've used. I deliberately did not use animal health examples because sometimes it's helpful for you to see other examples being used, and so you can begin to think through analogy. How might we use some of those other examples to build the case in building the bridge in policy for the work that we need to do? I would just say and echo Terry's comment that I do think that this is an important time for us to consider the coming together of public health and animal health and human health, because I think there really are so many things at stake for us to consider, and as it relates to policy development, to recognize the importance of strong and effective science, but also to recognize the importance of how we frame the issue and what policy tools we might choose in moving forward to develop an agenda that creates substantial and lasting change.